finish that off and discuss another case today. Thanks again. I'm going to වැඩි ලබන මහන් සීලු ඒකට සයනකට වාඩි වෙලා හිටියද පවුනේ ඔයගොල්ලෝ මහන්සි වැඩි ඉගෙනගෙන වැඩි වෙලා මහන්සි හරිද? Right, so we're talking about stroke yesterday. We discussed the management of hemorrhagic stroke. And to a certain extent, ischemic stroke. ගෙදර වැඩ. Did you manage to find anything on blood pressure in hemorrhagic stroke? සසංක මොනවද හොයාගත්තද? hemorrhagic stroke වල homework करे नहीं. Who says that? You taught a lecture. मैं lecture करे मेरे बलांडे के लिए. हाँ? Up to date मत दी. Evidence for that? What is the study? Okay. Interact. Now, what is it? 1 or 2? What is it? Anything that shows that there is no benefit? Studied it properly. Right, so we're talking about ischemic stroke yesterday and we're talking about thrombolysis and reperfusion strategies. Right? Okay. So what are the indications for reperfusion? Shamali, indications for reperfusion. Hang in the indications for reperfusion in patients with ischemic stroke. Thrombolysis. I'm talking about thrombolysis. Spokesperson la පාවිච්චි කරලා කතා කරන්න බෑ. මොනවද අපි කිව්වේ? What sort of people would you thrombolyze? Time is important. Okay, 4.5 hours. තා මොනවද කිව්වේ? You consider the NIH score. Did anybody find out the cutoff? 20? What is the maximum NIH score? 14, not 25. 14, right? NIH score is important. Time is important. Tabanal. Yeah, so there should be a persistent or worsening neurological deficit. It should not be rapidly improving. Right. Did you read on the contraindications for thrombolysis? Also, there is a long list of contraindications. Hari. Okay. Hari? Right. Then I also told you that there are newer methods which have come in, thrombectomy, and now people are also looking at extending this time window of 4.5 hours based on POSH imaging, which looks at what area of the brain is really infarcted and dead. Right, whether brain tissue is salvageable. Right, so that's a newest trend in stroke. Fine. Okay. Now, in Sri Lanka, we find that most of the time we cannot thrombolyze our patients. Right, that's mostly the case. Why is that? What is the reason for that? Yeah, most often we find it's a time. Yeah, time. So you need to know these things because at the exams we will ask you how many patients have you seen being thrombolized. 0 ne? Yeah. That's not because you have not gone to the neurology ward, neither. It's because we don't do it very much. No, actually we don't do it very much. One major problem is time. Now, that is because number one, the patient comes to hospital late most of the time. සමහර දවසක් ඉඳලා ලෝක අඩු වෙයිද කියලා බලලා වගේ තමයි එන්නේ. That's one reason. The other reason is, what is the other reason for this time problem? Yeah, it's a lack of access to imaging. That is the problem. CT. Lack of access to CT. That is the other problem. So in Sri Lankans, you have to know the practical thing. නැත්නම් උඹලා ගිහලා හැම එකටම thrombolyze කරනවා කිව්වොත් එහෙම problem because you have to be aware of the practical setting. In Sri Lanka, we have a lot of problems because we don't have access to CT machines. Right? That is a problem. Even in this bloody hospital, there are 3 CT scans. You can't get a CT done sometimes. It's absurd. There is no other word for it. Absurd. I'll tell you what. Now, when a patient comes with a suspected stroke, where is the patient first admitted? Under ETU. Yes, very good. ETU. Right. Now, where are the CT machines located in this hospital? Where are CT machines located? How many CT machines are there in this hospital? 3. Where about are they located? Neurotrauma, radiology, main radiology. Yeah, something in the neurosurgical unit also. Right. Okay. Now, if you are a rational person, ET වල ළඟම තියෙන CT machine එක කොතනද තියෙන්නේ? Neurotrauma. So, if you are a rational person, where should this CT be done when a stroke patient is admitted to the ETU? Neurotrauma. Yes, because it's just on the other side. ETU එක මෙතන, neurotrauma CT එක මෙතන. But like most things in Sri Lanka, what happens is, no, neurotrauma එක trauma CT විතරයි. So what happens is the patient has to be taken from this end of the hospital to the main radiology to get the CT scan done. Okay, so imagine the absurdity of that. CT machine එකක් එහා පැත්තේ තියෙනවා on the other side of the ETU, but you have to take the patient to the other side of the hospital to get the CT machine, CT scan done. Right? And how do you take this patient? No, not a trolley. Hema plate ambulance. Right. So what will happen now when the ETU chap calls the ambulance fellow? No ambulance. No ambulance driver. Ambulance driver is sleeping. Right? So it's absurd. So even in the National Hospital of Sri Lanka, we can't get a CT done in the allocated time. Right? So imagine the absurdity of this whole situation. Right. In other countries, the ETU is here, CT machine is next door. Right? And their stroke systems are so developed that they thrombolize on the CT table. The thrombolysis is given on the CT table. Right? They do the CT, and they have all this, and you don't have to search for consultant. When the CT is done, it's automatically uploaded into an online database. Anybody can access. So if you have a query, you can directly call the neurologist. He just looks at it, and then pataskala decision is taken. Right? So it's so quick. Right? Everything is automated, and there are lots of checklists and things that people do. Right? Here it's horrible. So don't even talk about it. So even in a place where there are 3 CT scans, still you can't get these things done. Right? So practical problems are there. Right? Because the administrators are generally not in this world. I don't want to use other terms. Right. Right. So most of the time we end up not from. The other reason is we don't have, sometimes the drug is not available. So you need to discuss these limitations if somebody asks you about thrombolysis in Sri Lanka. Right? නැත්නම් ඇමරිකා විදියට ගෙන වැඩක් නැහැ නේ. Right. So there are problems. So as a house officer, sometimes you have to fight to get the CT done. I have fought with so many people. I don't know how to fight with people, but basically it's absurd. Patient is in the ETU. I was a registrar. Patient in the ETU, young fellow with a obviously thrombolizable thing, but put up a bag with a time. call the neurotrauma නෑ එහෙම අපි CT කරන්නේ අපි කරන්නේ trauma CT විතරයි. And by the time next door මේ by the time patient මෙයා වෙනකොට මේ ambulance එක එනකොට වෙලාව ගිහින් ඉවරයි. Pointless. Right. Okay. So that's a problem in Sri Lanka. So if you cannot thrombolize a patient, what do? What are the other things that you would do now? Well, most of the time you will be seeing patients who are out of this inclusion criteria for thrombolysis. Hello. We thought you were in a delirious alcohol fast food. Come. People said that you had withdrawal and various things. Alcohol withdrawal. Right. Okay. So what do you do? Now, general management of a stroke patient, what do you do? So thrombolize කරන්න බැරි නම් මොකද කරන්නේ? What do you do? Well, correct. Yeah, what you can do is antiplatelets, statins that you have to do. Give. Aspirin is a usual drug of choice that we use in the acute stage of stroke. Aspirin and a statin. Okay. තාම මොනවද දෙන්නේ? Aspirin, statin and clopidogrel. Okay, so මෙහෙමයි. Now aspirin, statin is a usual therapy, but remember if a patient comes to small stroke, right, minor stroke or a TIA, there is an indication for dual antiplatelet. So එක වරහන් ඇතුළේ ලියා ගන්න. Usually we use single antiplatelet therapy in stroke. The exception is if it's a minor stroke. So it's a small lacunar stroke, minor stroke, you can use dual antiplatelets up to 3 months, right? Combination antiplatelets up to 3 months. There are lots of trials that show that it is beneficial, so it's evidence based, but that's only for small strokes or TIAs, right? Minor strokes or TIAs, you can use dual antiplatelets. Right. Okay, so that's it. So aspirin, statin, dual antiplatelets in selected patients. What are the other aspects of the management? Blood pressure management is very important and you need to be well aware about it. Right. Okay. Anuranga, what do you know about blood pressure in ischemic stroke? What do you remember about blood pressure in ischemic stroke, hypertension? Chamalka, you remember anything? What? Yeah. So Chamalka is correct. You have to be very careful about the blood pressure management in ischemic stroke. Right? Okay? You have to be very careful. Well, it's a problem. A blood pressure too high is also dangerous in ischemic stroke. Why? If a blood pressure is very high, can cause bleeding into the infarct. That's one problem. Okay? But on the other hand, a low BP or a rapidly dropping BP is also dangerous in stroke. Right? So that's a problem. So too high blood pressure is also a problem. Low or rapidly dropping blood pressure is also a problem. Right? High blood pressure is a problem because it can cause, very high blood pressure is a problem because it can cause bleeding into the brain. Right? Why is the low or dropping blood pressure also dangerous? What is the problem? Yeah. Remember that high blood pressure after stroke is a common thing. It is actually a reactionary compensatory mechanism. Right? Why does that occur? Because it tries to increase the blood pressure because it wants to perfuse the barely perfused areas. That's called the what? Penumbra, ischemic penumbra. Ischemic penumbra is an area, sort of a circular area around the infarcted, so the middle part of this is infarcted, it's gone, you can't salvage it. The penumbra is not dead yet, but it's just barely perfused. So actually what your body tries to do is it increases the blood pressure to increase the blood flow to this surrounding rim of ischemic tissue. So actually blood pressure elevation after a stroke is a normal, it's actually a compensatory mechanism. Right. Hari. So the penumbra is a very important area because that area is not dead yet, it is salvageable, right? It's ischemic but it's salvageable, it's not dead yet. So what happens if you suddenly drop this blood pressure? The blood flow to this region will suddenly fall, okay, and that area will also get infarcted, right? You remember something like this, neither? Cerebral blood flow and blood pressure, right? The problem with this penumbra area is what is called this curve where the blood flow is maintained despite fluctuations in blood pressure. So cerebral autoregulation. In a stroke, in this penumbra region, this autoregulation is gone. So the moment you drop the blood pressure, the cerebral blood flow also falls. Usually what happens is there is a defense, there is a plateau defense area. But in a stroke, this autoregulation is completely gone. So in this penumbra, if you suddenly drop the blood pressure, the whole thing gets infarcted. The patient will have a massive stroke. Right? Now this is a very important question we ask you at long cases, vivas, about blood pressure and stroke, because you need to be very well aware of it. Because we see so many patients, they go to the general practitioner with a stroke and they give nifedipine or something to reduce the blood pressure, and they come with worsening of weakness. It's a very common problem, right? So you need to know. So is that very clear? So high blood pressure causes bleeding, rapidly dropping or low blood pressures can cause infarction of the ischemic penumbra. So you need to be careful, right? Okay, so what are the upper limits of this management? If your blood pressure is more than 220/110, right, either you have to manage it, right? You have to manage it, but manage it gradually. Don't suddenly drop it, but you have to manage it with generally with intravenous labetalol. That's a common drug that you use. So cutoff is quite high, 220/110. Up to that point, don't do anything, nothing. Athavat tiyanna epa blood pressure එක. Right. එහෙම lower value එකක් නෑ, but generally say 160-140 range. Okay? But remember, there is a small thing that you need to know. If you are thrombolizing a patient, this value is different, and you start managing the blood pressure at any value above 180/100. Right? That's only if you are thrombolizing. If you are not thrombolizing, the management value is 220/110. If you are thrombolizing, it's slightly lower. So don't manage the blood pressure until it exceeds these values, right? If you are thrombolizing, it's lower. The cutoff is lower. Yes, so we prefer to use IV labetalol when you are managing hypertension in stroke. Why not give oral and just forget about it? It's easier to give. Why do we have to use IV? You have never thought of that? Okay, action has to be fast, but there is a better reason for it. Yeah, you can manage it nicely. Now, if you give oral drug, if the blood pressure falls, you can't suddenly take it out of the system. But if it's IV, because these IV preparations have very short half-life, the moment you reduce the rate, the effect goes away. So you can manage it carefully, or the better word is you can titrate it better. So you can increasing the rate, reducing the rate, you can titrate the blood pressure and be under control. Giving an oral drug, you will lose your control. But you're on control if you are using an infusion or IV drug, you know වැඩි නම් පොඩ්ඩක් you reduce the dose ඒ වගේ. So you can control it. Huh? Yes, infusion. Labetalol infusion. Labetalol boluses දෙන්නත් පුළුවන්, but stroke we generally give a infusion. Labetalol is the best. What is the problem in giving IV GTN? Now that can cause to lower the blood pressure, because you asked that question. Ravindra? But how? Yeah. So the problem with IV GTN is it causes vasodilatation. That can worsen cerebral edema. So we generally don't use GTN. Labetalol is available now. So don't worry, you can get it without a problem. The problem with GTN is causes vasodilatation. Right. Okay. That's about the blood pressure. Right. Now මොනවද කරන්න ඕන? Stroke, we couldn't thrombolize. We have given aspirin, we have given atorvastatin, we have managed the blood pressure if required. What are the other things that you have to do? How you can? What did you say? Kian Lagmi? Yes, you're correct. So, managing the patient in a stroke unit has shown to significantly improve outcomes. Right? Stroke unit care. Stroke unit. And that is lot of evidence to say that it is useful. Lot of evidence. Right. Managing the patient in a dedicated stroke unit. Malcha, why do you think it's useful to manage the patient in a stroke unit? You can give multidisciplinary care, very good. මේ ප්‍රශ්නම තමයි exam එකේ අහන්නේ. Multidisciplinary care, what is the other reason? Sorry? Yeah, it's targeted for stroke, but there is a very important reason. It's one-to-one care. So in a stroke unit, there is one nurse per patient. Ideal stroke unit, right? So it's one-to-one care. And rehabilitation is much more successful. It's easier to do. This nurse will look after the one patient's bladder, bowel, skin, everything, right? And also the occupational therapist, the multidisciplinary team is there. Occupational therapist, physiotherapist, speech therapist is there. So all of them work together to rehabilitate the patient. That's why it's used. So it's one-to-one care, multidisciplinary team approach is why stroke unit care has been shown to be better, right, than just managing the patient in a ward. Right? So rehabilitation, skin care, swallowing, bladder, bowel care, all of these are done in this. Right? So that does not mean that you should neglect these things. You have to do them as much as possible. Right? In a busy medical ward, stroke patients are usually neglected, but you try to do as much as possible for them. Right? Rehabilitation, physiotherapy, occupational therapy, their usual care, day-to-day activities, you have to try to do. Right. Okay, so that's important. What are the other important things you do after stroke in the management? Okay, sugar management. Okay, you are worried about hypoglycemia, right? So monitor the sugars. What else? Metabolic. Okay, electrolytes in some cases. More important than that. Complication prevention, that's through good rehabilitation. But you also want to prevent aspiration, bed sores, all of that is through good nursing care, right? Rehabilitation. Skin care is very important, right? And inspecting the skin, good nutrition, all of that is important for skin care, right? Cleanliness, good nutrition, inspecting, looking for bed sores, all of that is important. Remember, if you have a patient with stroke who gets a bed sore, that means you have failed in the management, right? So you have to always look into these things when you are a house officer. Right. Temperature management. Yes. you have to treat any infection aggressively, right? That's very important. You have to treat any infection aggressively. Common infections are UTIs, chest infections, pneumonias. Why are we so worried about infection in stroke patients? Apart from the usual problems related with infection, why did Vasana say temperature control? Because hyperpyrexia is well known to cause or increase cerebral damage. That's why. So manage the temperature, manage any infections immediately, because if you have sustained elevations in your body temperature, that causes worsening of your cerebral damage. That's why. Hurry. Okay. What else would you do in the patient's management? Tamanada karanne. Hasita tamanada karanne. What else would you do? Some cases you need to now look at secondary prevention. Secondary prevention. Bhagya katha. Hari. Kamana lajja inne pa katha kar. Right. Okay. So for that you have to screen for risk factors, right? Risk factors, the traditional risk factors we talked about yesterday. Echo, ECG, carotid Doppler, ඒවට කරන්න. So that's also a very important part of the management. Looking for risk factors and controlling them, because you want to prevent the patient from having another stroke. Sorry? Okay, any questions about stroke? Anticoagulation. Right. Anticoagulation is not indicated in stroke unless the patient has atrial fibrillation. Okay? AF තිබුණොත් විතරයි. This is too much for you, it's just because Swan asked the question. You only give anticoagulation in patients who have AF and stroke. Right, so it is ischemic.
INR is high.
Oh. Probably not, no. Warfarin with a high INR is a contraindication for thrombosis. Hari. Now, anticoagulation is only indicated in patients with AF. When are you going to start this anticoagulation? But then homework කරන්න නැහැ තේරුමක් නැහැ. So, if you like, you can find out. Do you start it immediately? Do you wait for 2 weeks? Do you wait for 1 month? Do you wait for 1 year? කවද්ද පටන් ගන්න? Find out. So anticoagulation only indicated in patients who have AF and stroke. No other indication. Huh? ඒක තමයි මම කිව්ව හොයන්න කියලා. සති දෙකයිද, දවසයිද, දවස් 3යිද කියලා හොයන්න. හරි. Antiplatelet therapy is for life. Right? It's for life.
So you can minus stroke with beautiful antiplatelets. That's for 3 months.
3 months. And then you continue single antiplatelet.
Is it aspirin or
Clopidogrel. ARM, carotid and vertebral duplex. හරි මොනවද බං මේ ලයිට් බලන්නේ? හරි ඔය කොච්චර බැලුවත් ඔය පාටම තමයි පේන්නේ. Around 200, 180, 200 CBS. Hari. Okay, stroke done. We'll discuss a very short, long case. Right. Question is, what antiplatelet do we use in the long-term management of stroke for prevention? Aspirin or clopidogrel? There's a bit of debate on it. Our unit we usually use clopidogrel. අපි සාමාන්‍යයෙන් දෙන්නේ aspirin we give it for 1 month and then switch to clopidogrel. But it's not a uniform thing. Some people use aspirin dipyridamole ඒ වගේ combination, but our unit we use clopidogrel. Aspirin for 1 month and then clopidogrel lifelong. ඒක වෙනස් වෙනවා unit එකෙන් unit එකට. Right? Bit of a controversial field. Nobody's going to ask you about that. Bit controversial.
Single antiplatelet do not try clopidogrel.
නෑ අපි සිංගල් ඇස්ප්‍රින් දීලා මාසයක් ඊට පස්සේ clopidogrel වලට මාරුවා. Dual antiplatelet දෙනවා මාස 3ක් dual දීලා then you give continue clopidogrel. That's the usual practice in this unit. Changes on in other units. හරි. දැන් මුන්ට පස්ස පෙන්නන් ඉඳපහ හරවන්න. හරි. Right, so this is not a long discussion. Just discuss a little bit about this problem, which is a rather uncommon problem, but it's important. Right, කියන්න බෑ.
47-year-old patient from Seedua, mother of 3 children, presented with pleuritic type chest pain during 2 weeks.
Pleuritic chest pain for 2 weeks.
Current condition related with some previous episodes.
Okay.
She is previously well before 2017 July. 2017 July is presented with left side unilateral chest swelling.
Left sided unilateral
Chest swelling.
Chest swelling.
With left side upper limb swelling and lower limb swelling. She also complained pain of the upper limbs, but no chest pleuritic type chest pain or no radiated to the upper limb. This episode which is associated with extrasenal dyspnea, but not associated with orthopnea or paroxysmal nocturnal dyspnea. And this episode also associated with
INR. මෙහෙම හරව. Right.
also associated with low grade fever with productive cough with yellowish color sputum. Sputum content is moderate, but it is not very with posture. Then she is admitted to the Rajendra Base Hospital, take a CT scan and echocardiogram. According to the result, she is transferred to the Colombo National Hospital. She was given by warfarin and symptoms are gradually relieved within 3 weeks. She doesn't have any symptoms.
So what do you think could have happened there? 2017. Patient comes with a very unusual symptom. කකුලත් තිබිලා තිබ්බ අත විතරයි නේද? අත නේද අත විතරයි. Right. So unusual symptom. Patient has swelling of the left side of the chest, upper limb swelling. Some difficulty in breathing. There's probably infection also that might have come on at that time. And she was started on warfarin. What does that indicate? Swelling of one chest and upper limb. Patient has been started on warfarin. What could be going on there? Huh? කොහෙද? Yeah, so there might be, the possibility is that there might have been a thrombus, right? In what vein? Vessel? Artery or vein? Vein. What vein? Subclavian vein. Left side. Subclavian vein. And maybe extending into some of these chest related veins also, right? So subclavian vein or jugular area, there might have been a thrombus. Hari. Then what happened?
During 1 year, right? 1 year, he was admitted to the thrombophilia screening for 2018 January. According to that, it was identified deep vein thrombosis in subclavian vein.
Okay. Deep vein thrombosis in subclavian vein.
2018 May, she was presented with left-sided lower limb swelling
Left-sided lower limb swelling.
in 2 weeks duration. Swelling is constant, no diurnal variations. It also contains rest pain in the left side calf, no numbness. When she is admitted to the NHS.
Hari, wait. What could be going on here? What could be going on there? No idea. Unilateral leg swelling. Patient had previously a thrombus in the subclavian vein. Now comes with left-sided lower limb swelling. If you are the house officer managing the patient, what are you going to think of first? Could this be a DVT on the left lower limb? For that, you need to ask him an important question, and that's the same question you are going to ask the patient or look at the clinic book for. What is that? Patient has subclavian vein thrombus, warfarin dunna, and now coming with a leg swelling, possibly DVT. What is the next question that you are going to ask? Think. This is not a long case, exam case, but this is an important problem that we are discussing. One, is the patient still on warfarin? Yes or no? Yes. INR. What is the INR?
INR is 1.3.
1.3. Is that enough? No. Okay. So patient has been on warfarin, but the INR is sub-therapeutic. And this has caused another thrombus. Okay? Right. That's enough. Right. Now what I want to teach you from this case is, first, why do you think this patient's INR was sub-therapeutic? As a house officer, it's one of your major duties to attend to that. So why do you think INR was sub-therapeutic? Tell me some causes that you might think. Commonest cause, patient has had a subclavian thrombosis. She is on warfarin, comes with another thrombus. INR is 1.3. What is the commonest cause of this issue? Poor compliance. Okay, poor compliance. Common compliance. She has taken warfarin. She claims to have taken it. තා මොනවද වෙන්න පුළුවන්? හරිද? Okay, there might have been an interaction with other drugs during this period of time. Good. Was she on any drugs during this period of time? No. Where warfarin has a lot of interactions with various types of medication. Warfarin dose may be inadequate. So for that, what is the next question you are going to ask the patient and Lakmin now? What dose is the patient on, and also? Yes? Previous, okay, dose changes, reduction of doses, and previous INRs. Yes, very good. So, she doesn't know. Has she checked the INR before? Regularly check करने के लिए?
After May, she was
She has been checking it, but she can't remember the value. Dose changes.
Initially, warfarin dose is 6.5 milligram
Per day.
per day. Now,
During this period,
it is
increased. So that would have told you that the doctors were not achieving the INR, right? That's why they have increased. So probably the dose would have been inadequate and they were in the process of increasing the dose. That when she got this. Sorry? Okay. What are the other causes for a INR like this? Yeah, there can be other factors that influence the INR, especially dietary factors, right? What sort of dietary factors would influence the INR? What? Consumption of? Yeah, what sort of? Green leafy vegetables that have vitamin K. Okay? Now, what the problem that occurs is, now you can take a standard amount of green leafy vegetables when you're on warfarin. Every day you take the same amount. But the problem is when you keep on changing the amount. Suddenly you take a lot, then you don't take anything, then again you take a lot. So that's why we advise patients to take the same amount of green leafy vegetables every day. Okay. Anything else you can think of? It's a very important problem. Tha monada wenna puluwa. No, but INR එක අඩුයිනේ මෙයාගේ. So it's not coming into the therapeutic range. What is the reason? Could be the reason for that. Any other? So we have talked about the common things. We have talked that the compliance might be poor, dose might be low, patient, there might be other factors interfering with warfarin, drugs or food substances. What is the other thing that you think of? Malignancy, it's a different thing. Malignancy. Rebecca, you're sleepy now? No. Tired, mahansi, gonna get a mahavadira mahansi. Yeah. Kaushika? Another very common problem is people change the brand of warfarin. These are practical things you won't learn in books. Leddu එක පාට ඒගොල්ලෝ පාවිච්චි කරන brand එක වෙනස් කරනවා. Now that's a problem. Sometimes people they start taking warfarin from the private sector, the good brand. කළා මේක ගත්තු ගමන් suddenly the INR falls because our one is not of good quality sometimes. So the INR drops. So that's why you advise patient to take the same brand of warfarin also. Right? Don't change because brands have different effects. Right? So there is, for example, there is a brand called Zofarin which is very strong. Milligram දෙකක් ගැහුවොත් INR goes up. But our warfarin is not of good quality most of the time. So it changes. So that's another reason. Hari. So that's one lesson that you need to learn from this patient. She's a patient who had a thrombus in the past, was on warfarin, and you won't expect another thrombus to come, right? But she had another thrombus, another DVT in her leg this time. So but the INR was subtherapeutic, so you have to look for the cause for that. Right. Before going on to the next thing, if she got a thrombus and the INR was therapeutic, what are you going to think of? Say INR was 3 or something, but she still got a thrombus. Yeah. That happens in malignancy-related venous thrombosis, right? So just as a special note, you write it down. Patients who have recurrent thrombosis while on warfarin or with a therapeutic INR, then the first things you think of is malignancy. Hari. Hari. So that's the first lesson I want you to learn from this case. Second lesson. What is the next automatic question that you are going to have with this patient? Okay, now you need to think. Now you are 5 weeks into the appointment, so you learn these sort of things also, critical thinking. Prasanka, what do you think? What do you want to know, or what is your curiosity now to find out in this patient? අතේ thrombus එකක් තියෙනවා, now කකුලේ thrombus එකක් තියෙනවා, but What natural curiosities are?
Whether there is pulmonary embolism.
Yeah, that comes later, but cause, yes, you have to find out the cause to it. What is causing this? What is causing this thrombosis? Right. From your experience, extensive experience as medical students, tell me some of the causes of recurrent venous thrombosis. Recurrent venous thrombosis. Sorry? Immobilization, okay. APLS, antiphospholipid antibody syndrome. PNH. So basically, you can have mechanical factors or things like immobilization. You can have thrombophilias, right, which are, some are congenital, some are acquired. Right? So those are the causes for recurrent thrombosis. Hematology module again was the congenital thrombophilias, protein C deficiency, protein S deficiency, not very important. Acquired thrombophilias are things like antiphospholipid antibody syndrome, malignancy related thrombophilia. Hi. Right. So that's the second lesson. Third lesson. Why is she having pleuritic chest pain and shortness of breath now? That's the current presentation, is pleuritic chest pain and shortness of breath. She says she can't walk, she can't climb stairs. What is the reason? Now, very good, yes. The first thing that you should think of is a pulmonary embolism. Yes, very good. That's the third lesson you need to learn from this case. A patient with past history of thrombosis, presenting with pleuritic chest pain, worsening shortness of breath, the first bloody thing you should think of is a pulmonary embolism. Right. Pulmonary embolism. Pulmonary embolism. Then INR is 0.9 or something. Huh? 1.03. Subtherapeutic still. Sorry. Okay, third lesson is that. Fourth lesson is, as a house officer, you have to know the advice you give a patient you are starting on warfarin. Very, very important. Right? So, pharmacology experts are somebody from the pharmacology distinction. Pharmacology distinction. How pharmacology? Pathology distinction. Pharmacology distinction is what? Motor pharmacology distinction. Hari. Udah tin. Hari. Kia bambalan? Hari. Award එක අයින් කරනවා දැන් මේ වැරදුනොත් එහෙම. What is the advice that you give a patient who is taking warfarin? කියන්න. සේනක බිබිලක ගලවනවා මෙන්න දැන් ඉවර නැත්තා. How do you start? Now this is a very important. අනිවාර්යෙන් බයි එක අහනවාම තමයි. At some point you are definitely going to get asked about this. Sometimes you might get a SCQ on this. ඉගෙනගෙන මහන්සි නැහැ නේ මේකත් කතා කරන්න පුළුවන්. කියපයියෝ. The first thing you have to do is you have to tell the patient what drug they are taking. Right? ඔයා ගන්න මේ warfarin කියන පෙත්ත කියන කියන්න ඕනේ. And the indication for that. Then what you said is very important. Proper, taking the proper dose at the proper time. Now, what is proper time? Malin? Ko. Senaka bibilek galawanna. Proper time? There is no proper time. Same time. So generally it's, you say 6 o'clock in the evening. Convenient time. So what is the name of the drug? Why you are taking the drug? Time, not to miss doses. Tamonadu. Talk out in the pharmacology distinction. No. Senaka bibilek ratayila bell America idanne mama danne.
It has to be taken 1 hour.
Yeah, generally you have to space out the meals. So if you are taking warfarin, 2 hours before, 2 hours after, you don't generally ask them to take any meals. Can interfere with the absorption, that's why. Hari? We discussed this, you have to consume the same amount of green leafy vegetables every day. Madhu Madhav? What a Koranamak net the Madhu Madhav again? Hurry up. Khan. Khan kiya bamba? Right, very good. Whenever you are taking treatment for anything, mention that you are taking warfarin to a doctor. It's very important. GP කෙනෙක්ගෙන් බෙහෙත් ගන්නකොට especially they give a lot of antibiotics, it can interact. The problem is that most GPs, when you become GP, who have warfarin ගන්නවා කියලා කිව්වත් they don't know what drugs will interact with it. But now because you have your external brain, it's easy because you can refer and find out. Hari. Have you got everything? Yes, very good. Recognize the bleeding manifestations and come immediately if they have any bleeding manifestations. Birthday girl? Chuti, ne? Professor Senaka Rajapaksa's birthday is also the 1st of January. Math professor කෙනෙක් වෙද්ද. Yeah. Yeah, so that we have discussed not to break the drug, not to
keep away from the deep contact sports like
රග ගහන්න එපා.
like
Contact what? Sports. Okay. Yeah, same brand we discussed. Something else? Huh? Yes, man, you have to monitor the INR. You tell the patient that monthly INR monitoring karanna කියලා. Monthly INR monitoring. හරි. දැන් ඔවා එකපාරට ඔලුවට කල්පනා වෙන්නේ නැහැ නේද? තව මොනවද? ඇයිනේ? Case of a mixed dose, do not take additional doses. තියෙන්නේ. ඔක දැන් ඔයගොල්ලෝ organize කරගන්න ලස්සනට. Right. Yes. What? Yeah. So in a female, you have to be, especially in childbearing age, you have to advise them about contraception, because warfarin is teratogenic in the first trimester. Contraception. Hari. Okay, so that's it.
During the same day, can they take the
Hari, so this is not a long case, but it has a lot of important problems that you need to handle as a house officer, right? Because now we need to focus on these things also, because we are running out of, I'm running out of things to teach you. We have finished most of the long cases, we are almost done now. So basically you have to learn about warfarin. You have to know about warfarin, right? Especially how to handle a low INR, sub-therapeutic INR. We'll discuss on another day how to do the reverse also when the INR is high. I think I asked you to read on that before, so at least some people. But here we discuss what are the causes of sub-therapeutic INR, what could be causing the recurrent venous thrombosis, what to think of if the patient comes like this with pleuritic chest pain and shortness of breath, right? We have discussed quite a lot of important things in this case. Hari. Okay? So, homework karanna hai, but if you are interested, read up about warfarin resistance. What that is. Warfarin resistance. Right. Right, so what did you learn today? Morning? There are lots of good cases in the male ward. You have to go and see them. One chap, of course, left. Systemic sclerosis guy. Yeah, දැකලා තියෙනවද නේද? You have seen the fellow? Yeah, මම දැන් ගියා. There is another good abdominal short case. Royal College එකේ groundsman හරි. තව මොනවද බෙල්? උදේ තව මොනවද බෙල්? Yes. Respiratory system examination bed 41. Now බලන්න ඕනේ ගිහිල්ලා. Have a look at this young girl in bed 25 also. She has chorea. Again, a very interesting patient. Patient who has had recurrent thrombosis in the past. Right? Arterial thrombosis. Vascular surgery එමත් කරලා තියෙනවා. Now she has 2 weeks of this progressive abnormal movement. Chorea. Right? So just have a look. Typical chorea එකක් තියෙනවා. Very typical. But we'll discuss that tomorrow when ready. Hari. Any questions? Problems? දැන් මානසික ගැන හිතන්න එපා. ඉගෙන ගන්න වැඩි වෙලා මානසික. ඒක වෙනස් වෙනවා. ඒ දවස්වල එක පාට ටැබ්ලට්ස් තිබුණා. මේ තැඹිලි පාට කහ පාට but now I think all are white color. Yeah. Those days we used to learn the colors. I think 2 milligram or orange and no, but now දැන් සුදුනේ. ආයි පාට තියෙනවද? කාලයක් තිබ්බ සුදු පාට ටැබ්ලට් විතරක් ආපු. now ආයි colors තියෙනවා. Yeah. So then find out the strengths. Yeah, හැමතිස්සෙම වෙන්න බෑ. සමහර කාලවලදී this color depends on the dose නේද ඉතින් 1 milligram එක නම් මැද ඉරක් තියෙනවා නම් කඩන්න පුළුවන්. හරි දැන් ඔය පරිස්සම ඊට පස්සේ සේන එක බිබිලේ වලවුන් ගෙන කියලා ඔය බෙල්ල මිරිකන්නේ. warfarin ගැන දන්නේ නැහැ කිව්වා. Fixed dose. Fixed. Started about 5 minutes, increasing. hari දැන් ගිහලා patient ටික බලනවල දැන් පොඩයි මෙතන renal patient කෙනෙක් ඉන්නවා bed කීයද second cubicle එකේ distal row එකේ මේ corridor එක ළඟ ඒ cardiovascular system එක බලන්න. Whose patient is that? වාගේ තියෙනව නේද? ඒක බලන්න. Tell me what it is. Some people can examine that patient. Some people look at this girl. People who are in the female ward in the morning go and look at the short case in the male ward, especially that abdomen. Royal College එකේ කවුරු ඉන්න එකකින් ගිහලා කතා කරලා shape කරගන්න. I think is a bit irritated now. මේ පොඩ්ඩක් shape කරගන්න. Royal isla ඉන්නව මේ. අනුරංග උදේ බැලුවා. නිපුණ ඉද Royals. අගිලා උ shape කරගන්න. Then yeah. No. එච්චරයි. හරි යන්න. වැඩි මහන්සි වෙන්න නැතුව බලන්න ඒවා.
stroke එකක් වුණොත් එහෙම cortex එක අපි කියන hemisensory loss එක කරනවා කියලා. ඒ සාමාන්‍යයෙන් කියන්නේ thalamus එකෙන් level එකකින් අපි අඳුර ගන්න කියලා sensor එක.
ඔව්. හැබැයි thalamus එකෙන් කියන්නේ ඒක හරි crude sensation එකක් තියෙනවා. ඒ කියන්නේ cortex එකෙන් නේ higher sensations ගොඩක් එන්නේ. ඉතින් patient thalamus එක ගියාම නිකන් pain එකක් අන්න ඒ වගේ නිකන් හරි crude sensory loss එකක් එනවා. ඒක
කෝටෙක්ස් එකේ කියොත් එහෙම නැති වෙන්නේ. ඒ කියන්නේ යාට පේන් නේද ඒවලගේ තේරෙනවා.
pain සමහරලාට තේරෙයි කර හරියටම but higher sensory loss එකක් තියෙනවා යාගේ කියන්නේ. හරි crude sensory එකක් තියෙන thalamus එකේ.
ෆික්ස් එක තැනම හරියටම normalize කරන්න බැරි. හවසෙන් විදි ගන්න
කොහෙද?
තාත්තේ කැන්ටර් සර්ජරි කරලා ගෙදර ගිහින් දානවා තාත්තේ.
දැන් මේ මූ නෑනේ කවුද වෙනව? හා? නෑ නෑ අපේ ආවෙත්. යාළුවා ටැමිල් එක්ක එනවා.
එනවා සර්.
මූ නෑනේ. උදේ ආවෙත් නෑ.
yesterday no sir මේ workනේ university ගිහම ඕකනේ.
Episode done. He's going to have to repeat it.
It was like that. It was like that.
පාඩම් කරනවා නේ ටිකක් දන්නවා. බයි වැඩක් නැති. අපොයින්ට්මන්ට් එක නැතුව. වැඩ කරන්නේ නැහැ. කොකෝ ටෙඩු ගන්න.
No, that's like that.